So welcome to the last in-service today, August 23rd, 2022. And we're going to listen to Hannah talk to us about all the new things that are coming or out for osteoporosis. And Hannah, I'm turning it over to you. As always, before Hannah you get started, do remember that if you have a question and you don't want to wait because you're afraid that you might forget about it, please, if you want to, go ahead and use the chat. It's perfect. So Hannah, turning it over to you. Hannah, we can't hear you. You're talking, you're muted.
Okay, can you hear me now?
Yes, ma'am. Now I'm going to go back to mute myself.
Thank you. All right, thank you, Dr. Baldwin. I just wanted to let you all know that I do have a handout that has the bulk of my information on it that was sent to you all through email from Dr. Baldwin. My PowerPoint is just very general information, but this has the bulk of it. So just refer to that, and I'll be referring to my handout a lot of times. But my name is Hannah, and I'm a fourth-year pharmacy student at Campbell University College of Pharmacy Health Sciences, and I'm doing my geriatric rotation with Dr. Baldwin. And I'll be talking about osteoporosis. After my presentation, I want you all to be able to recall the definition of osteoporosis, its risk factors, and how the disease is diagnosed. And also to discuss treatment options for prevention and treatment of osteoporosis. A little background about osteoporosis is that it literally means porous bones. Our bones look like honeycombs, and as adults get older, the holes in our bones, tiny little holes, become bigger. So then our bones become more porous, less dense, and weak, and that can lead to fractures. And fractures in older adults are more likely to occur in the hip, spine, and wrist. And it is more common in postmenopausal women over the age of 65 and men over the age of 70. And I have heard of some older adults, they can easily just bump into a side of a table, and that can cause a fracture with our very high risk patients. There is also called juvenile osteoporosis that I just wanted to touch on just a little bit. It's a rare disorder that can occur in young children, but it's usually caused by secondary causes, such as certain medications, autoimmune diseases, hyperthyroidism, parathyroidism, and Cushing syndrome. And I'll be talking about other risk factors for osteoporosis, and that can be the same for young children as well. So that's not an all-inclusive list. But with this, it increases their fracture risk, causes bone pain, hump of the spine, sunken chest, limping. It can impair their growth and can actually collapse the rib cage. And here is a picture of osteoporosis. The top box is what our bones usually look like. And then the bottom is an osteoporotic bone. And as you can see, the honeycomb holes get much bigger. So a little background, 54 million Americans suffer from osteoporosis, and 1 in 2 women and 1 in 4 men over the age of 50 with osteoporosis will break a bone. And since we all are dealing with our seniors, this is why this is very important to know what osteoporosis is and why it's important to not let, to prevent them from falling. And also 20% of individuals who break a hip may die within a year due to the complications associated with breaking the hip. They're not able to get up and walk, their quality of life is decreased, and just a lot of complications can occur. So how does osteoporosis happen? So our bone remodeling occurs in 2 phases. Osteoclasts break down bone, and osteoblasts create new bone. In osteoporosis, osteoclasts begin to break down more bone than the osteoblasts can create. And a lot of our osteoporosis medications can target these phases. Some risk factors are certain disorders such as autoimmune, digestive, neurological, nervous system, blood, endocrine, and kidney disorders. So like with autoimmune diseases such as rheumatoid arthritis, that has been known to cause osteoporosis because your body is attacking your joints and bones. And also patients are not able to be as mobile as they are supposed to be, and that can cause to weakened bones. Digestive disorders, any like malabsorption can cause osteoporosis because vitamin D and calcium is important for bone health. And if patients aren't able to absorb the calcium or vitamin D, that can cause weakened bones. And then with neurological and nervous system, just patients are not as mobile. And then blood disorders, endocrine is a big one. So estrogen plays a very important role in osteoporosis. So why it's more common in postmenopausal women is because once women hit menopause, estrogen declines rapidly, and that increases bone metabolism, so that weakens the bones, and so that will lead to the weakened bones. And then kidneys are important for absorbing vitamin D, and if we don't have enough vitamin D, then that can weaken the bones. And then mental illnesses, just not having a good diet, maybe, or just not getting out of bed when people are going through a mental illness. Cancer, a lot of chemotherapies can cause osteoporosis. Bariatric surgeries, that is like our gastric bypass surgeries, that causes a lot of malabsorption, and so we're not getting patients aren't getting the nutrients that they need for making strong bones. And then medications such as chemotherapy. And then proton pump inhibitors are a very important one. A lot of patients are on these, and proton pump inhibitors are Nexium, Prevacid, Prilosec, or Protonix, and they help decrease the acid that is produced in the stomach for if patients have like acid reflux, GERD, stomach ulcers. It can be used for numerous things, but they unfortunately have we need acid in our stomach to absorb calcium. So when we use these proton pump inhibitors, it's decreasing the acid in the stomach, so you're not able to absorb calcium, and we need calcium for strong bones, and so that's why they are linked to osteoporosis. And then with steroids is also another big one. 5 milligrams or more of a steroid for 3 or more months can increase the risk of osteoporosis, because it increases bone breakdown and increased bone metabolism. And then a lot of anti-seizure medications, such as like phenytoin, Dilantin, and methotrexate is also a big one. So how is osteoporosis diagnosed? It's diagnosed with a DEXA scan that detects bone loss. And then a T-score is calculated and compared to other healthy adults in their 20s. And once patients get the DEXA scan, this is a result they will get is the T-score. And as you can see with osteoporosis, a negative 2.5 or lower is indicative of osteoporosis. And then severe osteoporosis is if they have the negative 2.5 and then at least 1 fracture. And this is what a DEXA scan looks like. It's a pretty easy procedure. It's just like an X-ray. You just lie down. It's non-invasive or anything like that. And so it's really easy to get these scans done. And I will talk about who should be screened for osteoporosis. So women greater than the age of 65 years and older, and then men greater than 70. Women who are postmenopausal, and then men 50 to 69 years old with clinical risk factors, which I had just mentioned. And then adults with a non-traumatic fracture 50 years and older, and adults taking medications with associated bone loss, which I just talked about. So now I'm going to talk about some non-pharmacological treatment options for the prevention and treatment of osteoporosis. And so osteoporosis can be prevented in childhood because no one is never too old or too young to develop osteoporosis. And as children grow, bone mass increases until it reaches something called peak bone mass. And peak bone mass is reached in our 20s. And those who have a higher peak bone mass are at a reduced risk of osteoporosis. So it's important to get a lot of vitamin D and calcium and some other options that we'll talk about to prevent osteoporosis, but also it can be used for treatment as well to build strong bones. So with vitamin D, the recommendation is 800 to 1,000 units daily. Most Americans do not get enough vitamin D in our diet, and that is why we are seeing an increased rates of osteoporosis in Americans because, well, patients are living longer, but also our diet is not, we're not consuming enough vitamin D and calcium that we need for healthy, strong bones. And it starts in childhood. And I know as a child, I didn't drink a lot of milk and dairy, and I'm regretting that now because I know my bones are probably not as strong as they should be because I did not consume a lot of dairy. But we can get dairy from different sources such as milk, a lot of fortified cereals, salmon, tuna, and then there are supplements such as vitamin D2 and vitamin D3. And then our calcium sources, so women 19 to 50 and men 19 to 70 should get 1,000 milligrams. And then as when women and men get older, they should get 1,200 milligrams because they're at the highest risk. But Tums and Oscal contain calcium carbonates, and that's a good way to get calcium. And then also calcium citrate, which is Citracal. That's a good way to get calcium. These are supplements, but if a patient is on a proton pump inhibitor, like I had just mentioned, then the calcium citrate is more preferred in those patients. And then dairy, we can get calcium from, of course, our dark leafy greens, which is like broccoli, spinach, turnip greens, collard greens, etc. Salmon and soybeans, cereal, and even juices like orange juice contains calcium. And this is straight from one of the guidelines, pretty much how to calculate how much calcium that patients would be getting from what they eat at home. And this could determine if they need to supplement with a calcium supplement. Because, milk contains about 300 milligrams of calcium, and then, yogurt, 300 milligrams, and so on. You all can read all of that. And it says to add 250 milligrams to this once you calculate it for non-dairy sources. And then if they're getting under, the 1,200 milligrams, then supplementation is recommended. Some other non-firm treatment options is weight-bearing exercises such as walking, jogging, stair climbing, Tai Chi, and even dancing are great ways to keep the bones strong. And then limiting alcohol, avoid smoking, even removing fall hazards to prevent falls, and then correcting vision impairments, such as patients who may have glaucoma, macular degeneration, or even diabetic retinopathy. So a lot of patients with diabetes, their nerves in their eyes are affected, the blood vessels in their eyes are affected, so that can affect their vision. So it's very important, to get regular eye exams to prevent, having bad vision and then end up falling and breaking a bone. So when should we treat patients with the pharmacological treatment options? Well, if they're diagnosed with osteoporosis, if they have a hip or vertebral fracture, if they have low bone mass with small fractures, if they're on any high-risk medications or have any conditions, and then if they have a FRAX 10-year risk score of 3% or greater in the hip or 20% greater in the other osteoporotic fractures. And this FRAX score is an online tool that estimates the risk of someone having a hip or major fracture within the next 10 years. So pretty much if the patient is high risk of having a fracture, it could be appropriate to treat them. And treatment options are different between men and women. For women, as you can see, these are listed here, which I will go more into detail with them. But then for men, you can see that estrogen therapies is not one of the recommended treatment options because with men, they really don't need the extra estrogen. And with women, estrogen is essential for bone health. So first line option is our bisphosphonates. You all have probably seen a lot of patients on these. It's alendronate, which is Fosamax, abandronate, which is Beniva, resingenate, which is Actonel or Altelvia, and zolendric acid, which is called Reclast. So with our oral bisphosphonates, it's important that these are taken on an empty stomach 30 to 60 minutes before any eating, drinking, or medication to increase absorption. And then you drink it with a full glass of water, and you want to remain upright for 30 to 60 minutes because these are known to get stuck in the esophagus, and that can cause inflammation and difficulty swallowing. Some side effects of these are low blood calcium levels, difficulty swallowing, inflammation of the esophagus, and then osteonecrosis of the jaw and atypical femur fractures are very rare, but they are a listed side effect. And so when patients see these, they kind of freak out, but it's very rare, and these can be prevented from getting any dental, for the necrosis of the jaw, getting any dental work prior to beginning treatment. And then also there's something called a bisphosphonate holiday, which I would talk about on the next slide, but this can also prevent these rare side effects. And then with our IV bisphosphonates, flu-like symptoms are the main symptom. And then these work by stopping the osteoclast activity, which is what breaks down the bone. So bisphosphonate holiday is stopping the bisphosphonates to prevent the rare side effects of these medications. If patients are at moderate risk of breaking a bone, after 5 years of getting oral therapy or 3 years of IV therapy, they can stop and take a break from taking the bisphosphonate. They don't have to be on it very long term. But then they need to get routine bone scans to determine if they're losing more bone density. And if they are, then it could be reasonable to start bisphosphonate therapy or another therapy again. And then high risk, they can be on it for 6 to 10 years of oral and 6 years of IV. And then I will talk about estrogen. This comes in many different forms: tablets, capsules, patches, etc. You may have seen like Clemera, Estrace, Premarin, but these are more used for prevention of osteoporosis because it gives these postmenopausal women estrogen to help with bone health. And it can also treat menopausal symptoms, but it's more used for prevention instead of the treatment of osteoporosis. There are some side effects of increased risk of cancer, especially breast cancer, and then it can increase your risk of blood clots. Raloxifene is also called Avista, and this is approved for the prevention of breast cancer and also osteoporosis. So patients who are at high risk of breast cancer or who have a history of breast cancer, maybe a family history of breast cancer, and they're concerned, they can take this, and it can also prevent the risk of osteoporosis and treat as well. But this is a selective estrogen agonist / antagonist that just helps decrease that bone resorption. So it prevents the breakdown of the bone. And side effects include blood clots, hot flashes, and leg cramps. Next is a conjugated estrogen called Duavy, and it's approved for women with hot flashes, and it helps prevent the osteoporosis after menopause. And this is only to be used in patients who have a uterus. And that is because with estrogen, you have to have progesterone as well. It's kind of a complicated thing, but pretty much if you take estrogen, you need progesterone if you still have a uterus. And then that base-dioxyphene is kind of like a form of progesterone. And side effects are muscle spasms, nausea, diarrhea, and blood clots. And any of these estrogen therapies are contraindicated in patients who have already had a history of a blood clot or even cancer, or breast cancer, besides the raloxifene that's used for the prevention of breast cancer. Next, I will talk about our parathyroid hormone analogs. This is a daily subcutaneous injection. This one is not very ideal, I believe, just because who wants to inject themselves every day when there are other options? But sometimes we may have to use other options because maybe side effects associated with other things, or with bisphosphonates, patients have to remain upright. So if someone is bedbound and they're not able to get out of bed, bisphosphonates would not be the ideal treatment for them because that can increase their risk of the medication getting stuck in their throat and causing that really bad inflammation. Although there is the IV option of the bisphosphonate. And this is more recommended in very high-risk patients who have maybe fractured their spine. And this works by stimulating the osteoblast activity. So it's helping build the bone, and some side effects are orthostatic hypotension, which is a big side effect. And when injecting this for the first time, they had to be monitored by a healthcare provider. And it can also increase blood calcium levels. There is a black box warning that may scare patients of osteosarcoma, but that was mostly seen in rats, but it is a black box warning. Next is Prolia, which is a R-wrinkle inhibitor. It inhibits osteoclast activity, so it stops the breakdown of the bone, and it's approved for osteoporosis for those who have failed or are intolerant to other therapies. And this is given every 6 months, and the biggest side effect is just having the hypersensitivity reaction to the injection. Eventy, which is romosozumab. That's a long word, but this is a monoclonal antibody that is injected every 12 months. And after a year, they have to switch to another agent. And the first line agent would be the bisphosphonate. But it inhibits a protein that blocks the formation of bones. And the main side effect is joint pain. But there is a black box warning for MI, stroke, and cardiovascular death. So any patients who have a history of any a heart event, this is not a ideal drug for them. It's actually contraindicated. And the last one is calcitonin salmon. It's an intranasal single dose nasal spray. This is like rarely used. It's more last line, and it's mostly used in other diseases of the bone, such as like Paget's disease. But I won't go into detail about that. But it's approved for women at least 5 years postmenopausal, but it is reserved for last line. And some side effects is inflammation of the nose, nosebleeds, allergic reactions, especially those who are allergic to fish because it contains salmon. And then it does increase the risk of cancer. So this one's not an ideal medication. So it's not recommended, but the goals of treatment is to reduce bone loss, prevent fractures, and prevent pain and disability. And does anyone have any questions?
I was trying to unvideo myself. Does anyone have any questions for her?
I have one about Prolia because it's just advertised so much. But from what you presented, it seems like they have to have had no success or other medications not work before they get to Prolia. They just start with Prolia.
So yeah, it's approved for those who have failed or intolerant to other therapies. So I know with bisphosphonates, like I said, if patients are not able to stand upright for 30 or 60 minutes, they can't use the oral bisphosphonates. And a lot of the IV of bisphosphonates, like are reclassed, they do have some adverse effects, such as like really bad flu-like symptoms. I know with my grandma, she was pretty sick after she had the infusion. So I would say this one would fall into place if maybe they've had the reclass and they just had a bad reaction to it, then maybe this would be a good option for them. And if they weren't able to take the oral bisphosphonate. And maybe that's all I have. I don't know, Dr. Baldwin, do you have a better answer? Oh, we can't hear you.
Muted myself because they're noisy. I believe, Judy, to answer your question, it is still considered right now second line behind the bisphosphonates. However, the data that Hannah correctly presented shows that it is, I believe it's quickly becoming a competitor to the first line, which are the bisphosphonates, the oral bisphosphonates specifically. Part of what makes it useful is it's twice a year, and it's one of the few drugs out there that we know improves bone density at hips and spine. It's marketed that way because they're trying to the makers of it, Judy, are trying to make it a first-line competitor, because one of the things that Hannah kind of alluded to is we're going to be seeing osteoporosis showing up in younger and younger people. We're going to be seeing it showing up in more men, which is why Hannah very appropriately, and I loved it, included what's for women, what's for men, because we're seeing it. The ages that people are supposed to be building good, dense bones, they're not as active. And so that's going to cause problems. And so I believe Prolia is trying to hit that niche right there, because the bisphosphonates are beautiful drugs. They're magnificent. They have issues, as Hannah already mentioned. Does that kind of answer, Judy?
Yes, because it just didn't make sense with seeing all the ads. And I have one more quick question. And if you covered it, I apologize, I missed it. I've had people who've been on like Fosamax and other things that needed to have dental work done, and the dentist said they couldn't pull their teeth or the tooth.
Mhm.
Can you explain that to me?
Yep. So if you think about it, our teeth are bones, and the bisphosphonates like Fosamax works by help building our bones and making it stronger. And if they're trying to drill into their teeth or pull a tooth, it can make it very difficult, and it can actually lead to the osteonecrosis of the jaw, which don't look at pictures, it's terrible. But it's a very rare side effect, but it can be prevented by not being on the therapy for dental work. I'm not sure how long patients have to be off of the medication before they get dental work, but it's recommended to, not start the bisphosphonates until they get their dental work finished.
Oh no, these are people who didn't need dental work, one on the medication, then needed to have a tooth that was severely infected pulled, and the dentist never said anything about, we'll talk to your doctor about coming off the drug. They were just told, I can't pull the tooth.
Yeah.
And it just left everybody going, okay, why? And it was just because they were on that medication.
As far as I know, it depends upon which one specifically, Judy. I believe they can do dental work. With Fosamax, the question is really, we don't know. The other two, you can do dental work. I just don't know how long you have to be off of the drug.
Yeah,
and by the other two, I mean specifically the two orals. I don't know a whole lot about reclassed. I mean, I do, but I don't know the parameters of that, as well as I know the parameters with Boniva and Actonel and Fosamax. We can look into it, but I'm not sure we'll be able to get you anything better than that.
Well, it really just dealt with extraction, because they were willing to, they could drill and fix the other teeth, but they wouldn't do a crown or extraction because of the Fosamax.
And that has to, like Hannah stated, that has to do with the fact that it's altering, it's an alter, but it stimulates the bone cells to grow in a way that's not beneficial. That's when they start drilling and all of that. Dental cleanings we want them to do, but some of that other stuff they're really hesitant on.
I can look into it though. And
thank you.
Mm-hmm.
Anybody else have any other questions for Hannah? All righty. Thank you, Hannah.
Thank you.
Thank you all for tuning in.